So welcome everyone to tonight's ESPGHAN webinar on the follow-up in celiac disease in children. This webinar is hosted by the Special Interest Group in Celiac Disease. And we have two speakers tonight. First, it will be Professor Luisa Mearing, who will talk about the follow-up recommendations in the ESPGHAN position paper, and then I will follow. So please go ahead, Luisa.
Thank you so much, Elin, for your kind invitation, and thank you to ESPGHAN, of course, to invite me for this webinar on the follow-up of children with celiac disease. Well, as you possibly know, 2 years ago, ESPGHAN published a position paper on this topic, and that was published in the Journal of Pediatric Gastroenterology and Nutrition. The whole paper, of course, you can read it in the journal, so I will only touch some of perhaps interesting topics for you. In any case, the position paper was based on the available evidence from the literature, and we formulated 37 recommendations. If I should make a resume of a summary of the position paper and the follow-up of children with celiac disease, I will say less laboratory tests and better assessment of dietary compliance, quality of life, and transition to adult care. But for you, I will give especially accent to the gap in knowledge that we identified in the follow-up of the children with celiac disease. Well, here you have the pictures of all the people who contribute on the position paper. And for us it was especially important to have also contribution of the Celiac Patient Society, the International European Association of Celiac Societies, and also to have the contribution of 2 adult gastroenterologists. And of course, dietitians and also very many of our colleagues. We also present in the paper a summary table of the revised literature. We revise more than 2,500 publications, and at the end we include 164. All the recommendations were discussed during meetings and commented by all the authors. And at the end, a recommendation was accepted after voting, and only if at least 85% of the co-authors agree. And in some points, and I will tell you later, we did not agree, we could not reach an agreement. Well, the first recommendation is about who should do the follow-up of children with celiac disease. And we recommend that the regular follow-up visits will be carried out by a physician and or a dietitian, and this is important, experience in managing celiac disease. And of course, who will do it is very much dependent of the local practices and possibilities. Anyhow, self-care treatment and management is not recommended. We identified a gap in knowledge because we need long-term studies on dietary compliance depending on who does the follow-up. Another recommendation is about the frequency of the follow-up visits. And I have to tell you that this recommendation is made based on experts' opinion because there is not or very, very little information in the literature. We recommend that the first follow-up visit should be scheduled 3 to 6 months after the diagnosis, but with easy access to the doctor or dietitian or whoever is doing the follow-up if earlier advice is needed. And that subsequent visits should be done every 6 months until normalization of tissue transglutaminase antibodies, and after that, every year of every 2 years. However, as I told you, very little information in the literature and a gasp of knowledge was identified because we need studies on the frequency of follow-up visits. Recommendations about what to control during the follow-up visits. We recommend that antibodies, IgA antibodies against tissue glutaminase should be controlled using the same assay that was used at diagnosis, because these antibodies are a good surrogate marker for healing of the small bowel mucosa. Another recommendation is that usually a complete blood cell count, iron, vitamin B12, vitamin D levels, liver enzymes, those things are usually done at the moment of the diagnosis. If they are normal, you don't need to control them every time that you do a follow-up. However, any abnormality should be followed and deficiencies should be corrected until normalizations. About screening for thyroid disease was one of these points that we could not reach agreement. So you see that we made a very, very careful recommendation saying that the screening for thyroid disease with TSH may be considered during follow-up, and that will be done at the discretion of the clinician. A very, very careful recommendation. This one is quite hard. Routine bone density screening is not recommended in children. However, about hepatitis B virus antibody levels, again, they may be measured in previously immunized patients. That is important if this is considered important in the population. So we identified gasping knowledge about the laboratory tests that should be performed, including vitamin D determinations and control of thyroid. About the assessment of the adherence to the gluten-free diet, I will not comment a lot because, of course, Elin is going to tell you a lot about that. However, we say that a gold standard method to assess adherence is missing. So the adherence to the gluten-free diet should be assessed multidimensionally through careful evaluation of symptoms, dietary intervention, and/or dietary questionnaires and laboratory tests. About the use in routine follow-up of a stool of urinary gluten immunogenic peptides, we say that more investigations are needed before a recommendation of the routine use of this test can be formulated. Again, gasping knowledge, the need for a reliable method to assess adherence to the gluten-free diet, and also studies on the performance of the GIPS determinations in clinical practice. What about a number of common issues during follow-up? For example, about catch-up growth. We say that in the pre-puberal or puberal child, if significant catch-up growth is not reached within 2 years after initiation of the gluten-free diet, and the gluten-free diet is properly followed, additional investigations should be done, including a consultation with a pediatric endocrinologist. What about lactose-reduced diets in celiac disease? They are only recommended in those children with symptoms suggestive of lactose intolerance that are adhering well to the gluten-free diet. About chronic tiredness, there is, and also about irritable bowel syndrome in children with celiac disease who are following well the gluten-free diet, we don't have special recommendations different than for other children with these symptoms. Here we have really a lot of discussions about how to treat sideropenia. Well, in young children with anemia, due to iron deficiency or folate or vitamin B12 deficiency, we agreed that they should receive supplementation in addition to the gluten-free diet, since improvement over time may take too long in these children. However, about supplementation in the older children, we had a lot of discussions, and at the end, we agreed that also supplementation may be considered for older children. In any case, the disappearance of anemia should be confirmed in all cases, and adherence to the gluten-free diet should be checked. And other causes for anemia should be excluded in children who do not recover despite a strict gluten-free diet. What to do in those children who had sideropenia but don't have anemia? Then we say that an expectant attitude may be appropriate. We say it may be appropriate. Very, very careful on a gluten-free diet as long as there is improvement in iron stores without supplementation. In any case, a quite clear gap in knowledge was identified about how to treat persistent sideropenia in celiac disease. What about assessing mucosal healing? Well, we have a good tool to assess that, and that is the determination of IgA against tissue transglutaminase. So we expect that a normalization of these antibodies after 6 to 12 months on a gluten-free diet. If this is not the case, the gluten-free diet should be carefully assessed, and the dietary compliance should be reviewed, and testing for antibodies using the same test from the same manufacturer than in the beginning should be done. We advise not to do routine assessment of mucosal healing by means of small bowel biopsies. We recommend considering biopsies only in selected cases, for example, when there are doubts about the original diagnosis or when we suspect an additional condition on top of celiac disease. There are gasping knowledge, however, in these topics. For example, what to do with these children with persisting slightly elevated levels of tissue transglutaminase antibodies. We don't really know what we should do with these children. A point about refractory celiac disease. Does it exist in children? Actually, we think not. It doesn't exist, or it's very, very, very rare. So we think that when you have a case of apparent refractory celiac disease in a child, other possibilities should be considered, including, very importantly, ingestion of gluten, and of course, the existence of other enteropathies such as Crohn's disease, autoimmune enteropathy, bacterial overgrowth, etc. An important point, assessment of health-related quality of life, because that is something that is completely forgotten during the follow-up. And of course, for the patient, the quality of life is very important. So we recommend to control the quality of life of the children during follow-up, and to do it using validated celiac disease-specific quality of life questionnaires. These questionnaires may be given to the children and to the parents during the follow-up visit or before, to save time, but will be commented the results by the person who is doing the follow-up, and to be discussed with the parents and if the children are old enough, or with the children. Well, this was a very important point because it was about unclear diagnosis of celiac disease, what to do with them. and the indication of a gluten challenge and how to perform a gluten challenge. So you have a child, usually has been done a diagnosis of celiac disease, not very well done, not clear. The child is following a gluten-free diet, and the parents come to you, doctor, please tell me if my child has really celiac disease. That's the situation. Well, in that situation, we recommend to do an HLA typing. That will be very important because if the child is not HLA-DQ2 or HLA-DQ8, the chance of celiac disease really is very, very unlikely. You should do a challenge in this situation, but just to put the child on a normal diet. But if you have to do a gluten challenge, how to do it? So we say that should be a daily ingestion or
Let's see, Luisa.
Hello? I don't know, you know, Elin, in which slide it was? Gluten challenge, perhaps?
Yeah, maybe the one after that. Yeah, you start there again. Thank you very much.
No, thank you. So I think that it was in gluten challenge. I hope so. With 10 to 15 grams gluten for 12 months, but to control, of course, earlier if the child has symptoms, and to control the antibodies 1 month after gluten challenge, and to do it every 3 months. And then if there are not symptoms, after 1 year, the child should be allowed to have a normal gluten-containing diet and to be followed once a year.
Let's see, it might be that Luisa has a bad internet connection.
And to be given during the gluten challenge, and also about how long it should be. So those are really gasping knowledge that are very important. Quantity of gluten in the challenge, the length of the challenge, whether intestinal biopsy should be performed before starting and or after the challenge. And of course, we need biomarkers of celiac disease specific small bowel damage. In special cases, for example, children with diabetes or IgA deficiency, well, for diabetes, we recommend to do the same follow-up, but to do it together with the endocrinologist or diabetologist and a dietitian who has knowledge of diabetes. And those children, we know that they need more psychological and social support. In children with IgA deficiency will be the same follow-up that in other children, but of course, a specific IgG tissue transglutaminase antibodies should be assessed. Potential. Well, potential children with potential celiac disease, we define them as children who had a specific celiac antibodies, but they have a normal small bowel mucosa. What to do with them? Well, if they have symptoms, a trial of a gluten-free diet should be discussed with the family, and eventually they can be treated. But if they are left on a regular, normal diet, we recommend an annual follow-up visit with attention for the normal growth and nutritional status, and also including in these children, yes, include assessment of bone health. And of course, duodenal biopsies should be performed in cases of appearance of symptoms or increase or elevation of the celiac antibodies. Very important to discuss this. Important it is a good communication of the diagnosis. To make a communication very clear that the celiac disease has been diagnosed according to the current guidelines, and to give to the parents and to the children all the results, serology, HLA, whatever you did, to give it to them. And also to communicate the need of a lifelong gluten-free diet and regular monitoring, and to show the patient where to get the monitoring. And we recommend to do all that orally, but also by written. And the idea of a celiac passport, with a kind of booklet when all these things can be written for the patients, was discussed and seems to be a good idea. On the other hand, the later risk for health should be brought into perspective without inducing fear of anxiety to the children of the parents. And very important also to give attention to the emotional and practical support from personal contact with other people with celiac disease, especially celiac patients associations and support group, to tell the people that they exist, to give them the links in the internet of the ways to find them, and because they can give a very important support to them. To have idea if also to look for if the children are coping emotionally properly. And if this is not the case, to give special attention to this point. However, there are very, very, very little studies on the effect of the communication with the parents and the patients, and the health status of the children. So this is also a point that should be investigated. At the end, a recommendation on transfer to adult health care. And again, we recommend to do it in a formal way in adolescents with celiac disease to facilitate the transition, and including a letter on translation to give the celiac passport to the patient, and that he or she can show it to the adult health doctor, providing all the data that have been used to do the diagnosis and also in the follow-up. But we need long-term studies on transfer of care from pediatric to adult medical care. So that is my presentation, and thank you very much for your attention.
Thank you, Luisa. Can you hear me?
Yes, very well. Yes.
I was a bit late logging in, but we have a question which has already been submitted. My name is Kjetil Størdal, by the way. I'm chair of the celiac disease special interest group, following in large shoes of others here. But the question is, Luisa, do you think there are traces of gluten in breast milk, and should we stop breastfeeding babies with early onset celiac disease?
If there are traces of gluten in breastfeeding, well, we were looking for that a time ago, and there are a lot of proteins in breastfeeding. No one of them, of the many hundreds, was gluten. in mothers who were consuming gluten. So I personally think that there are not traces and that breastfeeding should be recommended. However, we know very well that breastfeeding does not protect against celiac disease, so should be recommended like in every other baby, but not for protection of the disease.
Thank you. So if you have other questions, we have time also in the end to get questions and answers from both panelists. But I'm now happy to introduce the second speaker, which is Elin of Segerstad. Comes from Lund, Sweden, and she is going to present from a dietitian's point of view. So please listen to Elin.
Thank you very much, Hetty. Let's see, I'm just starting my... Can you see my slides now?
Yes.
Yes, okay, and not in the presenter mode.
Correct.
Okay. So thank you very much, Kjetil. I'm Elin of Segerstad. I'm a dietitian specialized in pediatrics, and I also do research in celiac disease. And I'll give the dietitian perspective on this. Let me start with a case of Anna. So Anna was diagnosed with celiac disease when she was 4 years. And her parents met a dietitian at the diagnosis to get education on the gluten-free diet. And Anna had regular follow-ups with her pediatrician every 2 to 3 years. She always had normal growth, no signs and symptoms from her celiac disease. And the parents, they self-reported that Anna is adhering to the diet and her TGDA levels were always negative. But at her last follow-up visit at the pediatric clinic, Anna finally meets a dietitian. And the dietitian actually finds out that Anna has quite poor knowledge about both celiac disease as well as the gluten-free diet. And the dietitian also identifies that Anna is eating gluten regularly without knowing it through breakfast cereals, some chips and sweets, and she started to drink beer without knowing that it has gluten in it. And this is not just a theoretical case. I've actually met several young people in this situation. So this is what I'll be talking about, this knowledge and how we can educate our patients. So when we talk about the long-term consequences of eating gluten, even though you have celiac disease, we can look into adults. And they have both higher morbidity and mortality if they have a poor adherence over time to the diet. And some of them are obviously overlapping with the signs of celiac disease you could see before diagnosing it, including nutritional deficiencies, poor fertility, osteoporosis, depression, and so forth. So it really makes a difference if we can help our pediatric patients to learn the gluten-free diet and to adhere to it on the long term. And also when we look at adults with celiac disease, we see that few adults actually have regular follow-up of their celiac disease, and it's more common that you have persistent symptoms and persistent mucosal inflammation. And the adherence to the gluten-free diet is typically lower compared to in children. But actually one of the risk factors are if you have been diagnosed with celiac disease as a child. So again, we as working in the pediatric care, we really have to bear in mind what we prepare these children for, because we know that the gluten-free diet is an excellent treatment, but not everyone are doing all that well. When I think about the treatment with a gluten-free diet in celiac disease, I think about it in a holistic perspective. That it's just not just the intestinal mucosa that we want healing. We also want to have a long-term health, free of symptoms, an adequate nutrition, and a good quality of life, just as Luisa talked about. And this all happens because of the adherence to the gluten-free diet. That's the essential part. And to be able to do that, you have to have enough knowledge about the gluten-free diet. And the dietitian is typically the healthcare professional that helps the patient with all of these different aspects of the gluten-free diet. So what we would do at diagnosis at the unit where I'm working is that at the diagnosis, we educate the patients and the family, both about celiac disease and the gluten-free diet in different type of perspectives, such as the practical parts of it, the sociological parts, and the psychological parts. So what is the gluten-free diet, and what are the consequences of gluten intake? How do you cook and bake a gluten-free diet? And what about minimizing the cross-contact, getting gluten from gluten-containing foods to gluten-free foods? Reading food labels and understanding them and interpreting them to make sure that you're actually picking up the right type of foods. And what about eating meals outside the home when you go to a restaurant or traveling or such things? How should you try to ensure that you're getting gluten-free foods? And also, obviously, nutrition in the gluten-free diet. So earlier this year, the first ESPGHAN position on the gluten-free diet was published in the GPGN. You can use the QR code if you want to scan it, and you'll find it. And we established that the gluten-free diet can contain a maximum of 20 milligrams gluten per kilo or liter of the food, and this is according to the Codex Alimentarius. And in the European Union, the legislation is based on this. We have not enough data about the actual gluten intake, what is the maximum, but we think that there's a slight individual tolerance, if you may say, but these amounts are very, very low. And we would not in clinical practice actually know if the patient tolerates 10 or 100. This is far too small quantities to talk about. We also talk about gluten-free oats that it may be included in the gluten-free diet, and you can include it from the diagnosis. We also stress the nutritional adequacy in the gluten-free diet, and we talk about healthy dietary patterns. And I'll show you a little bit more of the information that we have in this position paper. There are these infographics. These considers gluten cross-contact and how you can minimize that when cooking at home. And there are also educational material that you could use when educating families and patients on how to read and interpret food labels. And when we talk about, Luisa, you talked about nutritional status and if we should follow up these patients. And what's the nutritional status at the diagnosis of celiac disease in children? So nowadays, most of the patients will be normal weight, and it's equally similar if they have an underweight or obesity or overweight. So it's not like we saw some years ago that most were underweight. It's still such that we see some vitamin and mineral deficiencies at the diagnosis, and even children that have been screened in more general population screening, we can see these deficiencies even though they don't have any clear symptoms of celiac disease. And we also see that at diagnosis, they may have a reduced bone mineral density. And this also has been seen in research screened children. But then what happens when they start on the gluten-free diet? Well, on the positive side, there's data showing that most of the micronutrients will normalize with the gluten-free diet. However, this may take some time. Typically, the nutritional status will normalize also when it comes to the BMI. So 1 in 3 of those who were overweight or had obesity at the beginning, they will actually normalize their BMI. And there's an improved bone mineralization, even though children are not taking any supplements. So this effect comes from the mucosal healing and the improved absorption of nutrients in the gut. On the negative side, we actually see some data presented on that there might be an increased prevalence of some specific vitamins and minerals that you will see increasing over time. So this is more likely to be due to the gluten-free diet that itself, that sometimes it might not be adequate and have all the nutrients that's needed. And there's also data showing that children who goes onto a gluten-free diet may have a worse dietary quality. So this is something to bear in mind when you follow up children in the more, like as a dietitian, and talk about the nutritional parts. So these are the recommendations that we give in the position paper about the gluten-free diet. We have a gluten-free healthy plate showing some different alternatives to vegetables and protein-rich foods and grains and so forth. And we really stress that whole grains should be promoted in the gluten-free diet, because you actually remove the major sources of whole grain when you go gluten-free. So therefore the oats is particularly important, but also the different pseudo cereals. And that we help families to choose good quality gluten-free substitutes that are high in fiber, low in sugar, and have good quality fats. And that we can encourage people to make homemade foods as a way to get a healthier lifestyle, and also to promote fruits and vegetables. And these things together will actually improve the gluten-free diet in total and minimize the risk of deficiencies. So what I would do, and my colleagues at the clinic, what we would do at the follow-up when we see children again, is that we will continue this education that we started at the diagnosis, talking about the things, same things again, but stressing this transition thinking that the older the child gets, the more we talk straightly to the child itself and educate them on these different perspectives according to their age and maturity. We talk about different coping strategies and motivation to stay to the gluten-free diet, and talk about their practical everyday life. And also we assess the dietary adherence. And when it comes to the dietary adherence, we can again look into the adults and how they are doing. And there are some publications on that tried to test the knowledge of the gluten-free diet in adults. So they were given kind of a food test with food labels where the adults with celiac disease should identify the gluten-free and the gluten-containing foods in this test. And what is quite actually disappointing is that most of these adults are making errors, and not just one error, but several errors, showing that as a group, it might be that the group of celiac disease patients have actually an inadequate knowledge about the gluten-free diet. And in my experience, this may lead to in two different directions, both towards a poor adherence. You think that some foods might be gluten-free, but they're not. So you're eating gluten, just like the case Anna. You're eating gluten without really knowing it. But on the other side of it, some people might go on to having a more restricted diet than would be necessary, because they're not self-confident that they can choose identify these foods correctly, and they may think that some foods have gluten in them even though they're not. And I found one publication where they tested knowledge in adolescents with celiac disease, and even fewer of them had the necessary knowledge to identify gluten-free and gluten-containing foods. And their parents had a little bit better knowledge, but in my opinion, not a good knowledge enough. And this is something that we have to remind when we meet patients, because sometimes we may just ask them how they're doing with the gluten-free diet, but a self-reported dietary adherence to the gluten-free diet is just not reliable. They might not be knowing if they're eating a gluten-free diet or not. And what can we expect when it comes to adherence? This systematic review published some years ago showed that about 1 in 5, 1 in 4 will struggle in children, will struggle to adhere to the diet strictly. And one of the risk factors is actually the adolescents. And I think if you meet celiac patients, you know that this is a big concern. It's a difficult period in life, you can say. However, the systematic review couldn't really conclude that having a family member with celiac disease is influential on the child's adherence to the gluten-free diet. But one of the supporting factors is the parents' knowledge about celiac disease and gluten-free diet, and that will help with the child's adherence. But we really do not have enough data on how to support the dietary adherence. What should we as clinicians do if we find poor adherence in these children? And also we have to remember when talking about the dietary adherence to the gluten-free diet is that it's not a binary, it's not dichotomous. It's not that you're either non-adherent or you're adherent to the diet. And of course, as I just talked about, that if you're non-adherent, it might be that you're eating gluten voluntarily or involuntarily. As I see it, it's a scale. You might, if you're non-adherent, it could be either that you're eating practically just a normal diet. These patients are, in my experience, not very common, but they exist. That they eat daily large gluten amounts, or they might eat gluten weekly, or have them every now and then, or have a very high risk of gluten intake. You might not always be 100% sure that the patient is eating gluten, but you have a very high suspicion that they're getting too much gluten. And on the other hand, when we talk about adherent patients, we can say that, again, that we don't know exactly if it's 100% sure that they're strictly adherent to the diet, but you may think that gluten intake is very unlikely in this patient. And also that one group of patients that we see might be this overly restricted, very, very avoidant patients who have a fear of that every type of food will have gluten in them. And let me talk a little bit more about this patient group. In research, there are not many papers out there yet, but I think there will be more. And they're called hypervigilant patients. And these are the overly restricted gluten-free diet, meaning that they're excluding more foods than they should have to in order to be strictly adhering to the diet. Some signs could be that they keep a completely gluten-free home, even though it's basically not necessary. They might have a very high anxiety when they're eating outside of the home, such as at friends' house, or just completely avoiding to eat anything outside of the home. They take a lot of precaution, and maybe a bit too much actually, around cross-contact, thinking that things might have gluten on them that should never have gluten on them. And this is very much driven by a fear of being glutened or accidentally getting gluten. This patient group, as it's been presented in some papers, it was shown that they had a worse quality of life, that they had more anxiety and they worry a lot. And this all gets very tiresome and exhausting to be thinking about the gluten-free diet in this way all day long. And in US teenagers, in these publications, it was about 1 in 4 patients who showed some of this behavior. But when we looked in our patients in the south of Sweden, we saw that about 5% showed this behavior. So I think that it might depend, but if you work with celiac patients, you might recognize these patients and you should be concerned and help them out. So let's talk a little bit more on how we assess dietary adherence. And Luisa, you talked about trying to do it in a multi-dimensional way, because this is not very easy. We just don't have good enough measures. But what are we actually doing? Well, when asking physicians all over Europe, 93% of them always use the TTGA at follow-up. And of course, we know that TTGA is an excellent marker for diagnostic evaluation. We can even make the diagnosis just based on them if they're high enough. But we also have to remember that TTG has a poor sensitivity for mucosal healing when you're on the gluten-free diet. So it doesn't work that well when you have a child who already started the gluten-free diet. So what we did, we tried to compare the assessment that we as dietitian do. In our clinic, we do a very systematic assessment of the diet. We looked at in 135 children in our clinic, and we had parallel assessment. So both the dietitian assessment and the TTGA taken at the same time. The dietitian was not aware of the TTGA level at the time. And we saw that in patients where the dietitian assessed that this patient is not adhering to the diet, still 70% of those were TTGA negative. So this shows that serology fails to identify children who are non-adhering to the diet. And this has been shown in other studies as well when you compare these two measurements. So like Luisa already talked about, there is no gold standard, but we should try to assess it multidimensionally. So like I said, there is not a lot of data in approaches to try to adjust the poor dietary adherence, but there is some data that when you have dietitians involved in the follow-up care, they may help to improve a poor dietary adherence, and importantly, to identify specifically, or most importantly, the involuntary gluten intakes that the patient might not even know about. Then your dietitian, it could be very valuable in identifying that. And by improving the patient knowledge and work with motivation and coping and different practical strategies how to address it, it may be possible. And in my opinion, when I meet patients, I really try to understand why this child is getting gluten. Is it voluntary? Is it involuntary? And what is happening? In what type of situations? What type of foods? And try to enforce the motivation. Try to see what type of support may this child or adolescent get from its network, and to help the child to really find a strategy. How can you do it in a different way the next time you're in this situation? So to summarize, I think that we should have a holistic perspective when we manage and follow up celiac disease. We should work with this continuous follow-up and educate the patients, and work with this in this perspective of transition, that we should assess the dietary adherence by combining these multiple perspectives and dimensions, and that improving poor dietary adherence is possible. And I just want to show you before my end is that there are some educational materials that you can find on the ESPGHAN webpage. You can use this QR code, and these are things that you can show your patient that diagnosis, for example. So thank you very much for the attention.
Thank you, Elin. Very clear and nice presentation. And thanks for also addressing the topic of hypervigilance. We just had a chat last week about advertisements for gluten-free shampoo and toothpaste, and we shouldn't make life more difficult than necessary for celiac patients either. So
definitely
it
not.
needs to get into the gut to get any kind of reactions. So that's also one side of the issue. We have a few questions in the Q&A, so I will try to organize them based on, they are quite similar, some of them. So the first one, which is very relevant for your topic, Elin, is if you recommend any questionnaire or checklist to prove that the gluten-free diet is done well, which could be working specifically for adolescents.
Right, because there are some validated questionnaires, but mainly for adults. And in my opinion, they're not very comprehensive. But Margaret Wessels published a questionnaire for some years ago, and I think that is more specific and really addresses those issues that may be a problem. So I would recommend that one.
If I may comment, because this question, I think that is possibly the best available one for children and adolescents, but it's Dutch. I mean, it is for the Dutch population, and possibly if you use it in another populations with other eating uses that should be adapted, especially if it's, for example, I don't know, in a quite different region. I think in South Europe, for example, should be adapted. But the idea is a good one.
And at least, in my opinion, the majority of the question are still quite general, and it could be applicable to several settings. But I agree with you that in that case, it should be validated in your own region or country.
I can add the reference to the dietary questionnaire in the chat box, so you can find it. We have actually tried to use it in Norway. It works quite well, but it's a bit too strict. So even our dietitian failed, and she has celiac disease. So it needs to be adapted to the setting as well. There are some questions also, which I think we can merge together, about complementary feeding and when to introduce gluten, even though the guidelines say that we don't have any clear reason to or specific advices of siblings of those with celiac disease, etc., when they should be introduced. But that's your topic, Luisa. What do you say?
Well, it is my topic, but it's not a topic of the position paper of ESPGHAN, because of course the position paper is on the follow-up of children already diagnosed with celiac disease. But there are a lot of information about when to introduce gluten in the food of young children. And at the end, it seems that the moment seems not to be so important. And at the end, there should be follow the general recommendations. So, for example, in children of celiac families, because those are usually the families that are asking the pediatrician, when should we introduce gluten in this child? There is celiac disease in our family. Well, it seems that the normal recommendations that is usually from 4 months of age should be followed. The quantity is a different thing. And there are a number of studies, prospective studies, that are suggesting that the quantity may be important. The only problem is we don't know yet how much. So at this moment, I don't think that we are in a position to say so much gluten and not more than that.
Okay, seems like Luisa is freezing again.
Yes.
So we have more questions, and we'll continue with one which is for you, Elin. What is the kind of role of a dietitian when there are issues on
normal moment of introduction and a small quantities of gluten, even if we don't know what is small.
Right. So next question for Elin is about how are there any ways that dietitians can improve the adherence to the diet after providing kind of the basic knowledge of a celiac disease and gluten-free diet when there are problems?
Yes, right. And I said towards the end that it's really, in my opinion, it's really important to understand what type of food, where is the gluten coming in, and really try to work with that, to identify that. If it's in a specific setting, is it always in school? Is it always when the child visits friends, they go out together with their friends or so forth, and really try to address those specific moments and educate and try to find out what's the motivation of the child themselves. Is there anything that you can motivate? Sometimes in adolescent boys, you can motivate them by, well, if you stick to the gluten-free diet, then you'll grow. That could be one potential motivation. So really, that's why I really encourage you to be very curious, ask a lot of questions, and be interested in what they have to say, because we'll never find the answer if we scold them and tell them off and say that you should never eat the gluten. No, try to engage instead and be curious.
Then it's a question about what are your thoughts on young children not brought to annual follow-up or appointment because the parents feel that the child is well and they feel follow-up is not required?
I think that
Luisa,
yes, that's for me. Well, I think it's a pity. It is a pity, but of course you have for those parents and you have for those children, and if they you cannot force them to come to follow up, but you can recommend it, and also to make clear to them what are the advantages to do it so. And of course, in small children and young children, the control of growth is important. The control of development is also important. And well, I mean, to gluten-free diet, all what we have talked about, that is important. The deficiencies, if they were or they are, they should be controlled also. The only thing that you can do is to talk to them and explain them the benefits of the follow-up and discuss with them. And also, for example, if they don't do it, why? I don't know what is in other countries, but it may cost money to them, and not everybody has the money to do the follow-up. Another thing is that we said once a year, but possibly once every 2 years in children who are doing well is also a possibility, and we should not restrict everybody to that once a year. So all those things should be talked to them and discussed with them with respect, like Elin said, and curiosity also. Yes.
And if I may add, I mean, we work with children, right? So the children, they are our patients, right? Not the parents. And in my experience, you can still, if you have a 3-year-old, a 4-year-old, you can still use pictures and drawings and talk to them and ask them about their foods and what they like. I mean, you can still get a lot of good information and good interaction, even though you have very young children. So in my opinion, it's definitely a benefit.
Right, we have a couple of other questions that we should try to answer as well before we close. One is about how do you deal with patients who struggle emotionally with being different in a setting with no specific psychology support? Elin,
Can I ask? Yeah. So yeah, if you don't have any type of psychology, social worker, or some type of professional like that, I think as dietitian or even, of course, a pediatrician, you can still be able to help. And in that case, try to find out what type of social support does this child or adolescent have in their network, and maybe if they're engaged in the celiac society, are there groups there where you can meet others with celiac disease? And also try to work on strategies with the parents. Are there things that the parents or the school may be able to do to make it a little bit easier? But again, talk to the child and try to understand what's the difficult part specifically, and not just generally. So it's always easier to address when you know what's behind.
Anything to add, Luisa?
Now, in my experience, for example, the celiac camps, well, they are organized by the celiac societies, usually in the summer, and there is a week or something like that, that they go all together, teenagers with celiac disease or even younger children. And usually it helps quite a lot. That they feel much better and they learn a lot. And they are cooking in outside, but gluten-free. And well, those things are important.
Right.
Right. The last two questions are kind of a bit not specifically related to the question. It's about the role of TTG. One is if biopsies are positive, if the IgG TTG does not come down after a year, should we be worried about that?
Yes.
I would say no. If it's not normal, I would say no.
Yes, if the TTG doesn't goes down significantly after 1 year, you should worry about that. Because what is true that TTG is not a good marker for adherence to the diet, but it is a very good marker to mucosal normalization after starting gluten-free diet. So you should worry about that and to see what is happening. Possibly the gluten-free diet is not being followed as it should. And sometimes it's really a detective to find where is the problem, what is going on, and that working together with a dietitian is very, very much is essential actually in those cases. But in my very long experience treating children with celiac disease, at the end of the day, you find it and the antibodies go down. Yes. But you should worry about that. Yes.
Yes.
May I just modify your sentence, because I think it's a very clear difference between going down and coming normal, because becoming normal may take 2 and 3 years if you are starting at a very high level, especially if you're a female, if you're a teenager, and have unmeasurable high levels when you start. Sometimes they take years to normalize, but they should go down, definitely.
Significantly going down.
Yeah. In my experience, if they still have very, very high levels after a year or so, they're consuming considerable amounts of gluten. We're not talking about cross contact or some tiny amounts every now and then. If you have very high levels, then you will have a very high intake of gluten.
Yes, and in those children, because they exist with very low levels, for example, just above the threshold of normality, and they are keeping that. Well, there is some information that if you take a small bowel biopsies, usually they are normal. Of course, we need longer studies and better data, but in general, usually the small bowel is normal. Yeah. But then we are talking about very slightly increased tissue transglutaminase levels. Yes.
Right. So the last question is about seronegative celiac disease in the context of positive biopsies. If you have any comments on that. I actually had a presentation about that at last ESPGHAN Congress, and I think first of all we have to say that biopsies are not the whole truth, because they may be showing villus atrophy because of completely other conditions. So we should be very careful to use the term seronegative without ruling out other causes of having a normal biopsy, like for instance H. pylori infections or other types of food allergies, or it can be Crohn's disease. So
Exactly, and that is one of the situations when HLA typing is helping. Because the same that we said, if you have a patient with high levels of tissue transglutaminase, you don't need to do HLA typing, because only people with HLA DQ2 or DQ8 may make celiac-specific antibodies. The other way is also true. So if you have a patient with alterations in the biopsy, no antibodies, you can do the HLA typing, because this is negative. Well, celiac disease is not a possibility. So it helps you, really. Yeah.
Good point. Right, I think that was the last question, and I have to thank Luisa and Elin for
Pleasure.
Thank you.
yeah, and for attending. That's really nice. And I don't know if ESPGHAN has any count of how many attendants there have been in previous webinars, but this is a very high and well attended webinar, I would say. So I think it proves that this is an important topic. We are planning to have a new webinar on celiac disease by end of November. I tried to find the exact date, but it will be soon on the ESPGHAN website. So please attend again, and thanks to all of you for being here, and thanks to ESPGHAN for organizing so well.
Thank you very much.
Thank you to all of you.
Bye.
Bye. Bye.
Thank you.